you would please initiate the recording. There we go. We got it. So with that, I want to go ahead and make sure everyone has their screens on gallery view so that you can see as many of the participants as possible. And just a reminder that if possible, if your broadband capacity can stand it, please leave your cameras on throughout the time that we're together. So I'm Dr. Doug Patton. I'm the Dean of the Southwest Georgia Regional Campus for the Medical College of Georgia. I spent most of my career down here in Southwest Georgia, serving as a rural general surgeon. I'm facilitating today's session all by myself because Dr. Markowitz, who is normally with us, she's off in New Orleans helping to take care of her newborn twin granddaughters. Interestingly, her son up in Cincinnati and his wife also delivered a brand new baby boy this week. So she's got her arms full, literally. So I want to introduce our TeleDerm clinic health providers. So wave, if you will. I'm going to tap the screen for 1 second so we can see everybody. So as I go around, if you're here, just kind of wave so everybody can see you. Dr. Sam Whaling from Lee Medical Arts. Miss Lori Hutchins from East Georgia Health Center in Mount Vernon. Maisha McFarland from East Georgia Health Center in Soperton. There we go. Sabrina Watkins, East Georgia Health Center, Evans. Stephanie Cothran and Carolyn Jones from East Georgia Health Center, Baxley. Dr. Floyd Soriano and Phyllis Solomon from East Georgia Health Center, Metter. And let's see, Billy Stout, East Georgia Health Center, Sylvania. Afternoon, Billy. John Ferrier, East Georgia Health Center, Wadley. I also want to welcome our AU Family Medicine residents. I saw the room open up just a few minutes ago. Somebody in that room, let's see, there they are, they're waving, I see you. Thanks for joining us today. Dr. Jorge Cortez is the director of the Georgia Cancer Center, and he is the principal investigator of the TeleDerm grant. I'm not sure if he was able to join us today. And we have the dermatologist represented by Dr. Davis, Dr. Rabinovitz, and Dr. Buchanan. We have derm residents and medical students, and I'll get to some of the medical student introductions in a second, but we have our TeleDerm team. You see them up, some of them up there in the TeleDerm window, but we have Kenza Mamuni, Marisol Miranda, and Brenda Santillano handling the controls today. Kenza, at some point, would you put the link for the CME and CNE in the chat box? You can do that now. It'll be there, and then we'll repeat it a little bit later on. That would be great. We have medical students from all across the state participating today. I see on the screen Mackenzie Maloney, Gabriella Duchesne, Liz Aitken. I see Katie Lively joining us. She's from the Southwest campus. Have no idea where she is today. They're all over the place. And with me in the room, we have Misha Farsi and Sydney Greenlaw, who just happened to be here doing OBGYN, but I told them how much fun this was going to be, and they decided to stick around. So I may have missed some folks along the way, but if you would, this is a good time for everyone to enter into the chat your full name and your email address and what organization you are with, whether it's a clinic or MCG medical student or AU family medicine residency or whatever. All right, so today's agenda. Let's go to the slide, please, that has the agenda. We have that. Slide 2. There we go. As normal, we're going to take a few minutes here for the introductions, and then there'll be a didactic presentation, and Dr. Kendall Buchanan is going to share with us again today, and the topic will be dermoscopic features of squamous cell carcinoma. We'll try and leave some time for questions at the end, so be sure and take notes along the way, or you can enter them into the chat, and we'll try and have chat monitors to prompt those for us during that time. And then we'll move on to our two case presentations. The first one will be from Liz Aikens, fourth-year medical student at the medical college. And the second presentation will be by Maisha McFarland, who's a nurse practitioner with East Georgia Health Center. Then we'll wrap up and remind everybody about what's to come and how to get your continuing education credits, answer any last-minute questions, and move on. So with that, let's go ahead and move to slide 3, just as a reminder of what we're doing here. Project ECHO, again, stands for Extension for Community Healthcare Outcomes, moving knowledge instead of people. And that applies to both the provider side and as far as educating ourselves by learning from each other's experiences, but also how to be able to help patients closer to where they live instead of having to send them away for evaluations. Next slide, please. So the TeleDerm sessions, our design is to improve knowledge by telemedicine using teledermoscopy and teledermatology at the local level, and to help get you comfortable with this technology and develop relationships with experts who can help you approach these health disparities faced by the people living in the rural areas where you practice. Next slide, please. So as we mentioned earlier, all TeleECHO sessions are recorded, and by participating, you're consenting to be recorded. We appreciate that participation. Protect patient privacy. Remember, these are not consultations. These are educational sessions. So please do not mention sessions. Will be information again in the chat and on the last slide about CME. We collect data throughout the process, beginning with registration and planning. But as you participate, as you ask questions and answers, put things in the chat box. And if we have polls, those responses are all collected and collated and used to help us create reports, to share with other ECHO providers, but also to improve mostly what we're doing to help you be better at this. Next slide, please. All right, let's see, general Zoom reminders. There you go. Remember to keep your camera on and mute your microphone as much as you can. We understand broadband is a challenge in a lot of locations, so if your video is chewing up your broadband, we understand, but keep it on if you can. Type questions or notes into the chat. Raise your electronic hand during the question and answer sessions if you'd like to be recognized. Remember to unmute and speak up. Introduce yourself when you do that. Again, keep your camera on and use the gallery view. And then you can email Kenza at kmamouni@augusta.edu if you have technical problems and you can't chat. So chat's the easiest thing to do because that way we can monitor it with everything else. All right, next slide. So again, it's my privilege to introduce Dr. Kendall Buchanan, who is going to be our presenter today, talking about dermoscopic features of squamous cell carcinoma. Dr. Buchanan, you ready?
Yes, I am ready.
Thank you so much for presenting again. All right, look at those kids.
Yes, they are so much fun. Okay, so today we're going to be going over squamous cell. So I'm going to give a little bit of background. You guys are all familiar at this point with our two-step algorithm. So today we're going to be talking about squamous cell features on dermoscopy. So clinically, squamous cell carcinoma can present different ways. There's a bit of a spectrum. We can think about it in terms of pre-skin cancer, things like actinic keratosis, all the way to invasive squamous cell. So these are some examples of squamous cell carcinoma in situ, which is essentially squamous cell carcinoma that's just confined to the epidermis. You can have a pigmented squamous cell, and you can have high-risk squamous cell. And these are just a few more examples here. The keratoacanthoma type is usually rapid onset, tends to be painful and more nodular in appearance. And then not all things on the feet are fungus, believe it or not. So this is an example of a squamous cell carcinoma in situ in a patient. She had been treated many years for eczema and fungus. And then the patient on the right, this is just an example of how squamous cell can be very aggressive. this particular squamous cell had involvement of the facial nerve. So clinically, this tends to present as a pink papule or nodule. You can also have more of a kind of thin scaly plaque, which is what you see more commonly with squamous cell carcinoma in situ. Again, these are very common on sun-exposed sites. They can grow slow or fast. They can bleed and become painful. And as I mentioned, there's different levels of invasion. Actinic keratosis is what we sort of think of as a pre-skin cancer. These don't necessarily evolve in this progression to an invasive squamous cell carcinoma, but they certainly can. The reason we get squamous cell, most importantly, accumulation of mutations that usually results from, chronic UV sun damage, which can cause these different types of squamous cell. And this is just a little schematic here showing how both UVB light and UVA contribute to the development. Essentially, UVA generates reactive oxygen species, UVB causes DNA damage, and through that process, loss of the cell cycle, you get squamous cell carcinoma. So it is the second most common skin cancer. Remember, we talked about basal cell carcinoma about 4 weeks ago. It is the most common skin cancer in darker skin types like African Americans and Asian Indians. It affects about 1 million Americans annually, accounts for greater than 20% of skin cancers, and the incidence is increasing. And this is just kind of what I was talking about with the different levels of invasion. So you have actinic, you have a squamous cell carcinoma in situ, and then a more invasive squamous cell, all three present in one patient. So risk factors, number one, UV radiation. Also contributing include increasing age, lighter Fitzpatrick skin types, men usually more common than women, about 3 to 1. Immunosuppression, so solid organ transplants are significantly at increased risk, up to 250 times. And then chronic lymphocytic leukemia, there's also an increased risk about 8 to 10 times with that. HPV certainly, as well as environmental exposures. In skin of color in particular, you really want to look more for areas that are on non-sun exposed skin. So typical areas would be the lower legs, anogenital region, and the hair covered scalp. So UV radiation in skin of color is not as significant of a risk factor compared to Caucasians. We know that melanated skin has sort of an inherent SPF of about 13, depending on kind of the range of color. However, UV radiation can lead to BCC in skin of color. So in skin of color in particular, we look at risk factors such as chronic scars, which can often cause more aggressive squamous cell carcinoma and lead to an increased risk of metastasis. We also have things like chronic heat exposure. So you want to look for signs like mottled pigmentation. Usually the history is an older woman who's set by a heater for the majority of her life. We also have things like chronic inflammation. So things like discoid lupus or hidradenitis suppurativa, chronic ulcers, all these things can contribute to the development of squamous cell. And there is a greater risk of morbidity and mortality compared to Caucasians. And this is an example from the New England Journal of Medicine. This is something called erythema ab igni. It's not necessarily that your risk of squamous cell carcinoma is increased. This is just a sign that this patient has actually had significant amount of heat exposure. So squamous cell can also be very high risk, which accounts for about 5%, which causes 72% of metastasis and 83% of death. So high risk features, this patient is an example of a high risk squamous cell. We see the diameter is greater than 2 centimeters. It's also in a high risk site, which is the lower lip. You can also see this on areas such as the ear. And then other features would be poorly differentiated perineural invasion and invasion beyond the fat. So we've kind of talked about most of these, and then just remember that high-risk SCC has poor clinical outcomes. So when it comes to dermoscopy, we are going to look at several different features today. The first one we're going to talk about is vascular patterns. So vessels as red dots. So they can be clustered, and sometimes this can be the only feature you see. Usually you will also see some form of scale or crust. That's a frequent combination. So you can see these in melanocytic and non-melanocytic skin lesions. Usually in non-melanocytic skin lesions, you want to think about mostly squamous cell, but you can also see these with things like porokeratosis and also inflammatory conditions like psoriasis. These are a few examples here. On dermoscopy, you see these pinpoint sort of vessels as dots, and you see hemorrhagic crust. This was a squamous cell carcinoma in situ. On the nose of this gentleman, you have this red scaly plaque. On dermoscopy, you see multiple vessels as dots and these sort of yellow keratin plugs. This was a squamous cell carcinoma in situ. This is an example of the diffuse vessels as dots pattern. And then again, you can see more sort of vessels as dots and coiled vessels along with some honey-colored crust. This is actually impetigo. So this is my 7-year-old. So I just put this in here to say that clinical context is super important. Whenever you start really practicing dermoscopy, you always want to evaluate the lesion clinically as well as with your dermatoscope. Glomerular or coiled vessels. So this is sort of a variation of dotted vessels. These are often more dilated or tortuous, and they correspond to capillaries in the papillary dermis. So we call them glomerular because they look like the renal glomerulus. They can be focal at the periphery, or they can be diffuse or clustered. They can also be arranged in lines. So this is an example here. On this gentleman, you see multiple coiled vessels, multiple vessels as dots with some yellow scale and crust, and this was a squamous cell carcinoma in situ. Another example here, this sort of red scaly plaque. On dermoscopy, you see again these tortuous dilated vessels that look like the renal glomerulus. And what you would see on pathology is this full thickness squamous atypia with parakeratosis, which is retained nuclei in the stratum corneum. And then on higher power, you see these dilated vessels in the papillary dermis. And this was also squamous cell carcinoma in situ. Other vascular features, you can see vessels surrounded by a halo and twisted loop vessels. We've talked about halo vessels before, specifically with seborrheic keratosis and also with intradermal nevi. We've talked about twisted loop vessels in the context of basal cell carcinoma. So this is one of my patients here. She presented pretty acutely with this spot on her back that popped up within a couple of weeks. And so what you can see are these twisted loop vessels, hairpin vessels, and this sort of central crater of keratin, which is very classic for keratoacanthoma. Another example here, this patient presented with this red nodule on her leg. She had been using mupirocin, which can cause a contact dermatitis, but on dermoscopy, you see vessels with a halo and then also this central scale crust. And this was a well-differentiated squamous cell carcinoma, and sometimes we refer to this as a keratoacanthoma. So white circles, these often are seen with keratin or central yellow plugs, and we'll go over that. This is from a paper by Dr. Rosendahl. And so here's some examples of the white circle and then the keratin plug. Another example here of white circles, and then you have this keratin plug. The keratin plug is usually more palpable, sort of raised. And whenever you see these features, so keratin is highly sensitive for squamous cell carcinoma, and white circles tend to be highly specific. And sometimes this is all you will see. I have found that I see these more after a patient tells me it started to resolve. I don't know if that's just, anecdotal, but Usually, sometimes the redness and the vascular structures will be hard to see if you have a lot of keratin plugs. And this is another example from one of Dr. Rabinovitz's patients. Here, you see the white circles and the keratin, which corresponds to these keratin pearls on dermoscopy. So again, white circles are highly specific to squamous cell carcinoma. And then, sorry, my computer's, okay. So brown circles and brown dots. So you can see these sometimes together. The brown dots tend to be radial arranged, but these can be seen in pigmented squamous cell carcinoma in situ and pigmented squamous cell carcinoma. So here's an example here. You see these brown dots arranged in lines. And here you see some brown dots and circles. Sometimes this won't be as clear, and I think that it has somewhat of a smudged appearance. That's not going to be reported in the literature. This is just something that I've noticed over time. And here you have these brown dots and brown circles. These are courtesy of Dr. Rabinovitz. This was a patient, she presented with this sort of tan, brownish, scaly plaque on her arm. And as you can see on dermoscopy, you have hemorrhagic crust, you have a structuralist zone, you have vessels as red dots and brown dots. And so this was indeed a squamous cell carcinoma where you have the full thickness squamous atypia, parakeratosis, and then here you can see where there's increased basal keratinocyte hyperpigmentation, which corresponds to what we see with dermoscopy. Rosettes, we've talked about rosettes before in the context of actinic keratosis, and also you can see it with other things. These are a form of shiny white structures seen with polarized light. They are arranged in a flower-like or circular pattern, commonly seen in squamous cell carcinoma and also actinic keratosis, somewhere around 38 to 46%. And so here's an example here where you see, actually, this photo is a reminder to use alcohol. So this lesion has a lot of scale on it. So you need to apply more alcohol whenever you look at this with your dermatoscope. And so what you see are multiple vessels as dots. You still see the scale crust, but it doesn't obscure your view once you use a little bit more alcohol. And then you can see the multiple rosettes. And this was a squamous cell carcinoma. And another example here of this nodular lesion on the left lower leg, you can see scale crust centrally located. You can see dotted vessels and also rosettes. Squamous cell carcinoma. Usually, these are going to be the type that present fairly quickly, come up in about a month or 6 weeks, and the patient has noticeable pain or tenderness. Another example here, we see central keratin. It's kind of that orange-brown color. We have peripheral brown dots, or what I was calling the smudge appearance. And then you have multiple rosettes. And this was a squamous cell carcinoma. Yellow scale. So this isn't one of the fancy features, but it's very important. So always look for scale. As I mentioned earlier, scale plus dotted or glomerular vessels is a clue for SCC. And you usually don't see scale in melanocytic lesions. So if you're thinking like, could this be a hypomelanotic or amelanotic melanoma, but you see scale, you should really think about squamous cell carcinoma in your differential. You can see here, it usually comes along with blood spots, diffuse scale. Another example here, you have to use a lot of alcohol. Even with a lot of alcohol, it can still be hard to see because that scale crust is so thick. But what you will see is a lot of blood spots. And you have to make sure you look at the entire lesion with your dermatoscope. because occasionally at the periphery is where you'll be able to see your vascular patterns like vessels as dots. And lastly, the strawberry pattern. So this tends to present as like a red pseudo network, consists of redness or erythema with fine wavy vessels, usually centered around follicular openings. And you'll see a white halo. Rosettes are also very common. So here you see this strawberry pattern, red pseudo network, fine vessels, and white circles or rosettes. And then another example here, this scaly thin plaque on the forehead. You see the multiple sort of, well, you do see scale, and then you see these yellow follicular openings in this and rosettes. And this was consistent with an actinic keratosis. So in summary, non-pigmented squamous cell carcinoma in situ, we have vascular pattern that dominates, so usually dotted vessels or coiled vessels with scale crust and some micro erosions. Pigmented squamous cell carcinoma, brown circles, brown dots that are typically arranged in lines. You can also see structureless zones, vessels as dots, and coiled vessels. And then invasive squamous cell, scale crust, keratin plugs, white circles. Remember, those are highly specific. And vascular patterns. You can have multiple different vascular patterns, vessels as dots, coiled vessels, or twisted loop, hairpin, linear, irregular vessels. So if you have more interest in this, you can look up this paper by Dr. Zaludek. He kind of goes into the dermoscopic features of the progression from facial actinic keratosis to invasive squamous cell. Okay. So these are my references, and thank you guys for your attention. And then on December the 5th, we will be talking about melanoma.
Thank you again, Dr. Buchanan. That was fantastic. I can't monitor the chat, so I'm going to have to depend on the ECHO team up there if there are questions in the chat. Otherwise, does anyone have a question from the group for Dr. Buchanan? I don't see any hands raised. Students? Well, I have one for you, Dr. Buchanan. You caught my attention early on with the extraordinary risk that people who have immunocompromised states have for very aggressive squamous cell cancers. Solid organ transplant patients who are on chronic immunosuppression, you said up to 200 or 250 times the risk. For those of us who are out in practice in small communities, we may or may not ever have someone who's a solid organ transplant patient. Some of us do, but a lot of us have patients that are on chronic immunosuppressive therapy, whether it's steroids or biologicals or anything like that. Is there anything that we need to be watching for in that patient population regarding the risk of squamous cell, or encouraging them to take special precautions?
Not necessarily with like steroids and biologic. I think for our high risk skin cancer patients, those who have either had, strong history of sun exposure, or have had multiple squamous cells or basal cells in the past, or, are at high risk because of their transplant status, there are some things that we might recommend. For example, niacinamide is vitamin B3. And so sometimes in these patients, there's been a lot of studies done showing that if you take this vitamin 500 milligrams twice a day, it can significantly decrease your risk of getting actinic keratosis and squamous cell carcinoma. So that's one recommendation we make, as well as, frequent skin exams. So every 3 months, and these patients are the patients that you tell every time they leave that, please call if something comes up, because you will often have, these fast growing squamous cells or keratoacanthomas that, you can do the best skin check, and then 2 weeks later, they might get scratched or bump into something, and then a squamous cell carcinoma develops at the site.
That's great. Thank you for that. That clears up a lot for me.
I was going to comment. Yeah, so I think it is interesting that we have all these immunosuppressive drugs, but not everyone gets skin cancer. And so when you drill down to what medicines are really guilty, azathioprine over the years has been a really bad drug for putting people at risk for squamous cells. And so think of our transplant population, and that many of them are being transitioned off of azathioprine, which is probably a wonderful thing. But what we're running into now is a lot of our patients who've had long-standing inflammatory bowel disease and have been maintained on azathioprine, they're getting lots of skin cancers as well. So that particular drug is one that for dermatologists keeping us in business. So yeah, exactly. And so how mycophenolate as a substitute for that is going to pan out. But it is interesting, our lupus patients who are on prednisone, they do not, grow the squamous cells that we see in our transplant population and our inflammatory bowel disease patients. And I think that's because certain drugs like, especially azathioprine, have been bad actors over the years.
Great insight. Okay, well, if you have other questions or comments, be sure and make a note, save them, or put them in the chat, but we're going to move on so we can keep it going. And it's time for our second presentation. And this time it's coming from Liz Aikens, who's a fourth-year medical student at MCG, and she is going to present our first case presentation for the day. Liz, are you where you can share your screen?
Yep, I will go ahead and do that now. Please let me know if you can see the presentation view or the presenter view.
We can see it now. It's in presentation mode. Thank you.
All right, perfect. Well, yep, like you said, my name's Liz, fourth-year medical student applying into dermatology this cycle. So for our case today, I wanted to talk about this 54-year-old female. She came in for just a routine skin exam. She had no history of skin cancer, but we did find a thin, scaly pink plaque on her right posterior leg. She was unaware that it was ever there, so we weren't sure how long it was there, but it was completely asymptomatic. So for our clinical differential, there's a few things that we're kind of thinking, one could be the squamous cell carcinoma, potentially a superficial basal cell carcinoma, just by looking at it clinically, or an actinic keratosis, or maybe also a porokeratosis. And the reason why we're thinking all of these is because they can all present as the thin pink scaly plaques. So the first step, as always, is this melanocytic or non-melanocytic? And we're going to go ahead and say that this is not melanocytic. And we're going to say that because we don't see any pigment network, no brown globules or dots, and then also no homogeneous blue or brown patterns on our patient's plaque. So what do we see? The first thing that we see is what, we've kind of talked about before, these little red dots, and these are the vessels as dots pattern that we were discussing previously. But we also see a central scale in the middle of this plaque, and then we can also see this keratin rim. So this is just another picture, like we talked about earlier, of the atypical vascular patterns. Today we're just going to focus on the dotted vessels. So here's a pretty broad differential of all the things that we can see that may have vessels as dots. So over on the right side, these are the different melanocytic lesions that we can see that have vessels as dots. But as we said in our patient, we decided it was not melanocytic, so we're going to go ahead and remove that portion. But also clinically, we noticed that our patient's plaque doesn't really look like psoriasis clinically, also doesn't look like dermatofibroma, lichen simplex chronicus, or lichen planus-like keratosis. So this kind of leaves us with a squamous cell in situ, a porokeratosis, or potentially a clear cell acanthoma. So on the bottom, you can see all of the features that are associated with squamous cell carcinoma, like we discussed earlier. And for our patient's plaque, we do see the vessels as dots, like we mentioned. And we can also kind of see a central yellow scale, but we don't see any of the white circles, the brown circles, rosettes, brown dots, that strawberry pattern we talked about, or any of the hairpin vessels. So it's probably a little bit lower on our differential. We also want to make sure that this isn't a clear cell acanthoma. And one of the classic findings for a clear cell acanthoma is this string of pearls arrangement. So you can see the vessels as dots, but because of the way they're arranged, we don't really see that in our patient's plaque under dermoscopy. So again, probably less likely. But we do see several features that are associated with porokeratosis. So we're going to go over those now. And the first thing and the most classic finding is this keratin rim. And that's kind of what we talked about earlier. This is another example on the top photo. But we also see the dotted vessels like we discussed, non-peripheral scales. We do kind of see a light brown or brown gray dots at the rim. But then we can also find blood spots. And on the bottom, you can see a very small blood spot on our patient's plaque, but this top picture just shows a little bit closer up, more clear image. Histologically, we can see this keratin rim, and that's also known as a cornoid lamella. And so that's what we can see with these arrows here. The bottom picture is just a little bit more zoomed in portion of this section. And so we see the 45-degree column of parakeratosis, and that's pretty classic for the cornoid lamella under for what you can see histologically. But then we also see epidermal atrophy, solar elastosis, and then also a lymphocytic infiltrate here. So sometimes even under dermoscopy, it's not clear whether you can see the keratin rim or not. So one thing you can do is the ink test. And the way this works is you can just get a skin marker and you cover the entire plaque with the ink. And then you can wipe away the ink that you've just placed down with a alcohol pad. And the ink will usually stick to the keratin rim. And so that can tell you, maybe there is this keratin rim there, and then that can help kind of nail down your diagnosis. So in summary, we wanted to choose this case because we do see vessels as dots in melanocytic and non-melanocytic lesions. And although they can be characteristic for squamous cell carcinoma, they can also be characteristic for porokeratosis, especially when there's a keratin rim involved. Again, the key dermoscopic features that we see, the keratin rim, dotted vessels, non-peripheral scales, the gray-brown dots, and then blood spots. And then just remember that you can do an ink test if you're unsure at first or even under dermoscopy. So my one question for the ECHO team is there any risk of malignancy with porokeratosis? And this is actually something I've been kind of personally interested in ever since starting this case report that I've been working on with Dr. Potter. But we had this one patient who came in and they had a plaque that was originally diagnosed as psoriasis with a biopsy. And then it subsequently underwent malignant transformation to a squamous cell carcinoma 3 times. And then when they rebiopsied, they noticed that it was actually a giant porokeratosis. And so porokeratosis does have a risk of malignant transformation, but your highest risk types of porokeratosis are linear porokeratosis, which you can see on this picture on the left, and then also in a giant porokeratosis. And giant porokeratosis are usually defined as being about 10 to 20 centimeters in diameter. So that's kind of how you can tell the difference with those. But I would be interested to hear if anybody else has had this happen in their clinical experience. But if not, then thank you. And these are my references.
Thank you, Liz. It's a fascinating presentation, and a lot of similarities to other types of skin troubles. It didn't have a scale on that circular thing, but most of the time in primary care, when we see a ring-like lesion on people, it's some kind of fungus or parasite. So completely different story. And I've never, ever heard of using ink to outline it like that before. That was great. Any questions for Liz or comments from Dr. Rabinovich, Dr. Davis, Dr. Buchanan? I was just going
to say the risk of squamous cell and porokeratosis. So, there are lots of different types, but the giant ones we call the porokeratosis of Mabelli, and I have seen squamous cell develop in that type of lesion, and they get quite large. It's rare. Those lesions are rare. The disseminated variety that we see, I think there's much less risk. But the purple trick, patients love that. You know, when you show them that they have that rim, I mean, they think you are just amazing because, I mean, they've not been aware of that rim. It's kind of educational, patient and physician.
So over the years, I've seen a couple cases of squamous cell association with porokeratosis, but it is rare. It's been very difficult to treat over the years, whether one uses imiquimod or one uses 5-fluorouracil. But one of the new novel treatments is using a combination of 2% cholesterol with lovastatin. And it seems to be that many porokeratoses are actually due to a genetic mutation in cholesterol synthesis.
Interesting. Thanks for that, Dr. Davis, Dr. Rabinovich. Okay. Again, if you have other comments or questions, be sure to make a note, put them in the chat, but we want to keep it moving. And now it's time to turn to our second presentation from Maisha McFarland, nurse practitioner at East Georgia Health Center in Soperton. And Maisha, if you're ready, you can go ahead and share your screen and get started.
All right. So. All righty, here we go. Can everyone see my screen?
We can.
All right, perfect. All righty. So I had a 64-year-old Caucasian female that came in with a painful lesion to the right side of her face. She stated that it started out as flat, and now it had become raised and much larger over the course of about 3 months. There was scaling present, no drainage noted. She has a history of COPD, diabetes, hypertension, high cholesterol, fibromyalgia, and psoriasis. Patient uses hydrocortisone 1% for occasional psoriasis breakouts. No personal history of skin cancer. First degree family member had a history of melanoma. So my question was, how often do patients describe their lesions as painful? And if so, how often is it malignancy is diagnosed? I had not personally had a patient who had described a lesion as painful yet. So when she came in and told me that, that was very new to me. So I had, I hadn't heard that before. But we have, as we learned a few minutes ago with our presentation, most lesions that are squamous cell are usually painful. So this is a broad picture, but squamous cell carcinoma was our first differential diagnosis, often red, scaly nodules, maybe tender or painful, hypertrophic, trophic, actinic keratosis, difficult to distinguish from squamous cell carcinoma. Hyperkeratotic papule is often the only feature, and then basal cell carcinoma, pink, pearly papule, may ulcerate or bleed. Okay, so this is our dermoscopic image, and so we'll go through our algorithm. We have a lesion present, melanocytic or non-melanocytic, and it was non-melanocytic, so we go right here to our next diagram, and we see that we're going to go with the squamous cell carcinoma. So non-pigment network, no brown dots or globules, no streaks or radial streaming, no homogeneous pattern. So it's non-melanocytic. All right, we do have a keratin mass, the central scalar crust. We have some blood spots present. We have, peripheral vascular areas, and we have a white structureless area. And so, pro tip, if you press the mole scope too firmly on a skin lesion, the blood vessels will blanch out and appear as a pale white area on the image. All right, so I'm trying to move my green around. Okay, there we go. So features of squamous cell carcinoma and keratoadenoma. So white circles, ring-like structures around hair follicles, keratin mass, centrally located, yellow-white thick scale crust, white structureless areas, vascular structures that are mostly peripheral, and vessels with a halo, glomerular vessels, and vessels as dots. So this is kind of our process for treatment. We uploaded the image to the Derm Engine platform. Biopsy was suggested by Dr. Rabinovitz. His original diagnosis was squamous cell carcinoma, keratoactoma type. So I do not biopsy here in our clinic, so we sent the patient to the dermatologist where a shave biopsy was performed on one day. 2 weeks later, she went back and it had grown back in size greater than what it was. So they, after the shave biopsy, it was consistent with squamous cell carcinoma. There was perineural involvement, which is very high risk. There was involvement of a lymph node, which was also noted. So she had a Mohs procedure done and then had, I think, 13 weeks of radiation. They did a lymph node biopsy and we are waiting results for that. I'm not quite sure if we have them yet or if they haven't been sent to me yet, but we are awaiting those results. So questions for the ECHO team. What are the criteria of high-risk squamous cell carcinoma, and how closely should this patient be followed?
Thank you, Maisha. That was a great presentation. And I appreciate you tossing in that pro tip in the middle of it about not pressing too hard. That makes a big difference. I have a question for you. Did you do the shave biopsy?
No, sir. We are a very small clinic, so we did not do the shave biopsy.
Okay.
I referred her to dermatology. Yes, sir.
All right, good. I'm glad you're able to get some help with that.
Yes.
What other questions might we have or comments from the dermatologists on board? So her question was, the last question was, how closely should this patient be followed after the treatment's completed? Any thoughts about that? And what should we be doing in addition to not just looking at this one lesion?
So yeah, I would say, at least with your dermatologist, that patient should be seen pretty routinely, probably every 2 to 3 months. Make sure that patient has full skin exams. You'd want to, counsel them about risk factors, mostly being UV sun exposure, kind of starting to look at the, UV index is a good thing. Just kind of remind patients about peak sun exposure, UVA, UVB light, make sure that the patient is not, going to tanning beds, that sort of thing. Patient will need to follow up with the oncologist as well. So, definitely high risk. As Maisha talked about, the perineural involvement, usually size over 2 centimeters, invasion beyond the fat. Those are some other things. Locations like the lip and the ear also tend to be very high risk. So, some of that is depending on the guidelines that you read. I think the Brigham and Women's guidelines are a little bit easier to follow, but a lot of that information is determined based on the path report. But it is helpful if the primary care provider does a biopsy, very helpful to take a photo, record the size, and then especially head and neck, I would go ahead and kind of feel, if you feel any lymphadenopathy, especially in a larger lesion or a lesion that grows rapidly and then comes back rapidly after the biopsy.
So one other point is that at least clinically, it didn't look like a very large lesion. And the clinical really doesn't jibe as well with the histology. Another point is that there is a test actually where one can send for evaluation to see if this squamous cell carcinoma has the potential for metastasis. The test is used for melanomas, particularly melanomas that are 0.76 to 1 millimeter. And basically, it categorizes lesions into two categories, 1 and 2. 1 is highly unlikely that it'll metastasize, and 2 that it will. Well, they do offer the same test now for squamous cell carcinomas as well. So it's just another test to know when there's a question mark in terms of whether or not you think an individual needs to have a sentinel node performed. In this case, based on the perineural involvement, it was the right approach to do. But the lesion itself really wasn't that big, so a little surprising.
Interesting, but apparently it did change rapidly in size, which was always a little bit scary when it grows quickly like that. So
But
good.
KAs can do the same, though. KAs can go very rapidly over a short period of time, but it was very interesting and handled quite well.
Other thoughts, questions?
Also, we
Again,
have a question from Lorianne.
Yes, I do have a question. When you do encourage a patient to be with the UV exposure, what happens when it comes to vitamin D? Are they encouraged to take supplements or to change their behavior in terms of nutrition to make sure that they eat foods rich in vitamin D? Is there anything else done in that line?
It's funny that you bring that up. I remember watching, I don't watch TikTok, but I remember watching a video, and the dermatologist on there, she's board certified, she's amazing. And she said, I dream of the day that patients wear enough sunscreen, to knock out our vitamin D levels. So, it's kind of hard to say. I don't personally recommend that patients take vitamin D. I think, you can be careful about getting outside, like early morning, late evening. You're still getting a little bit of sun exposure, but certainly we always recommend that they follow up with their primary care provider, making sure they get their vitamin D levels examined. But I don't know, Dr. Davis or Dr. Benovitz may have another comment on that.
Yeah, I really think it's hard. I mean, most of us get enough sun just walking between buildings. I mean, I think we have to worry about our nursing home patients. I mean, they may never get out, and then you really have risk, but most of our folks are going to get enough vitamin D just in their everyday activities. And most dermatologists will say, if you're really concerned, you can supplement. I mean, there's nothing wrong with supplementation, especially after a certain age, especially in, women who are worried about their bones. So, I think that the patients who I have who tell me that they have to be outside for their vitamin D, I think that argument is something we can argue against, because there are other ways definitely to get their vitamin D. I wanted to make one comment, just because I may not remember to say this down the road, but as physicians and primary care practitioners, one of the things that we know now is that hydrochlorothiazide, which is a commonly prescribed drug, is photosensitizing. And so, I think in patients who are developing skin cancers, it would behoove them to change their antihypertensive therapy, because hydrochlorothiazide has been linked to skin cancers in fair-skinned individuals. And so, when I have someone who's developing squamous cells, I want to look at the whole picture, and not just whether they're immunosuppressed on azathioprine, but what other medicines are they taking chronically that might predispose them to having more sun damage, in their daily routines. And hydrochlorothiazide is getting a lot of bad press right now. And it's, a lot of people have been on it for years, and no one ever steps back and thinks, well, maybe we should stop that medication and rethink this in someone who's developing a lot of skin cancers, especially fair-skinned individuals.
That's just the perfect kind of advice that we need to hear. We have some of these old and very effective medications that are inexpensive and they've been working well, but we don't always recognize the underlying risks that they may be creating for us. So thank you for that, Dr. Davis. We're getting close to wrap-up time. Before we start dropping off, I did want to ask Brenda if she would to introduce two of our new guests that have joined us. We typically only have one person joining us from Florida. Today, apparently, we have two new guests joining us from Florida. Brenda?
Yeah, I want to say thanks for joining today to Margaret Bobonic, that's how you pronounce, and Mary Nolan. Both are dermatologic and nurse practitioner. They are both focused in education and research. And I want you, if you want to introduce or yourselves, Margaret, Mary.
Could I introduce them? These are two of the finest nurse practitioners in dermatology in the country. They actually have a one-year course to teach nurse practitioners dermatology. And it's been an honor to be associated with both of them over the years.
Thank you so much, Carol. I will say thank you for inviting us today. And this is tremendous to have this opportunity. And there's residencies and fellowships across the country that don't have access to this. And this is just fantastic. And I'm just blown away.
Mary?
I think students are just started nice little digestible segment that we can learn from is great for them. I'm actually from Boston and Margaret is from Ohio, but we teach through the Florida Atlantic University program. So thank you for inviting us and we'll be back.
Thank you, Mary. We had a little trouble with audio from you, but that's okay. We'll catch you back, and we certainly welcome both of you to join us back. So,
Yeah.
All right, we're at time, and again, I want to thank everyone who presented today, especially you, Dr. Buchanan, again for doing that all the way from South Carolina, and for Liz and Maisha for your thoughtful and helpful presentations. And for all those of you who joined us today, I hope you feel like you're getting something out of this. We certainly want to remind you about the CME and the continuing education credits. So if you can put that up on the slide and also put it in the chat, that would be great. We will be asking you periodically to fill out surveys so we can get the feedback. We also really want to take advantage of the opportunity now that, especially now that we have some others who are experts at the technique of teledermoscopy, if we can offer some special training on how to actually use the mole scopes and things, let us know that, because we want you to be comfortable with the technology. As a reminder, the next session will be Monday, December the 5th, and it'll be dermoscopic patterns of melanoma. We will be doing some best practices with the mole scope refresher. Dr. Whaling from Lee County and Aaron Hirsch and Jody Rye from MedOptima. And I think Jody is with us today. I thought I saw her name up there. They're from MedOptima, and they will help us do that. So remember in December to have your mole scopes handy, and maybe we'll have a little learning lab with that. So thanks everyone for attending. We'll see you at the next session. Again, check the chat for the continuing education information. And it's time to sign out. We're right on time. And for those of you who are part of the team, if you don't mind hanging out for a few minutes after for a little debrief. Thanks everyone.
Mm-hmm.